Good afternoon. So today we shall have a brief discussion about the antiarrhythmic drugs, that means drugs used in the treatment of the rhythm disorder of the heart. So to understand the arrhythmia, let's discuss the normal sinus rhythm, which is generated from the SA node, which is called the cardiac pacemaker, and that is, if the impulse is normal, that means SA node from after generation from the SA node, it is going to the AV node and then to the ventricle via the his bundle of His and Purkinje fiber. Then we call if the heart rate is normal, rhythm is normal, then we call it as a sinus rhythm. And there are specialized pacemaker cells which can spontaneously generate action potential. That means in absence of SA nodal function, there are also specialized pacemaker cells which can spontaneously generate action potential, and they spread through the conducting pathways, mainly bundle of His and Purkinje pathway, Purkinje fiber, to stimulate other parts of the ventricle. A normal sinus rate is 60 to 100 beats per minute. So these are the different conducting system of the heart. It is SA node is the primary pacemaker cell. We have ventricular muscle, Purkinje fibers, which is having the highest conduction velocity. We have atrial muscle, AV node, bundle of His, and left and right bundle branch. So bundle of His is divided into two bundle branches, left and right, and SA node triggers the atrial depolarization, and AV node is the only pathway for AP action potential to enter the ventricles. And atrial activation is complete 0.09 seconds after the SA nodal firing. Now, before understanding the action potential defined actions of the antiarrhythmic drugs, let's discuss the cardiac action potential. It is the action potential curve shown by the non-pacemaker tissue. That means the bundle of His, Purkinje fibers, or the normal ventricular muscle, those tissues showing these phases of action potential. Phase 4 is the resting membrane potential, and when there is action potential, it depolarizes cells to the threshold level, that is the minus 70 millivolt. And after that, there is beginning of the phase 0, and phase 0 is due to caused by a transient opening of the fast sodium channels. Then there is inward it increases the inward directed depolarizing sodium channel. So phase 0 is due to influx of the sodium channel, and it generates the fast response action potential. And after that, so here, look here, from the depolarization minus 70 millivolt, it goes to the positive, and this is due to rapid sodium channel influx. After that, there is, so this is the phase 0. After that, the sodium channel closed, and that begins the phase 1. So this is the initial depolarization. There is closure of the sodium channel and opening of the potassium channel. This is the transient outward hyperpolarizing potassium current. So sodium channel gets entered, that causes depolarization, and for repolarization to occur, potassium channel goes out. Transient outward hyperpolarization potassium current, and there is a large increase in the slow inward calcium channel occurs at the same time, and that begins the stage 2, phase 2. So phase 1 is the exit of the potassium channel, closure of the sodium channel, and phase 2 begins when there is simultaneous exit of the potassium as well as entry of the calcium. So large increase in the slow inward calcium channel occurs at the same time, and as there is a opening of the calcium channel and potassium channel at the same time, and potassium is going out, calcium is going in, so there is no change in the action threshold. This potential remains unchanged for a long time. This is called plateau phase. Okay? So repolarization is delayed due to this entry of the calcium. So this is the L-type calcium channel, opens at the minus 40 millivolt. So repolarization is delayed due to entry of the calcium channel. So this is called plateau phase, and plateau phase prolongs the action potential duration. So treatment of arrhythmia is generally, the heart is, so it arrhythmia can be tachyarrhythmia or bradyarrhythmia. Commonly we have to treat the tachyarrhythmia. Tachyarrhythmia means heart rate is faster than the normal expected, and we have to slow down the conduction. That's why we have to, how we can do that? Either we can decrease this phase 0 slope by inhibiting the sodium channel, or we can decrease this calcium entry, so that we can decrease this opening of the potassium channel, so that the repolarization phase is prolonged. So potassium exit is the cause of repolarization. If we can prolong the potassium exit, then repolarization phase will be prolonged. So thus we can have sodium channel blocker as well as potassium channel blocker to treat arrhythmia. Calcium channel blocker I shall discuss later, but these calcium channel blockers do not influence this plateau phase. Cardiac action potential. Next is phase 3, repolarization. So potassium channel remains open still now, and inactivation of the calcium channel. So remember, phase 0 is this rapid influx of the sodium. Phase 1 is due to closure of the sodium channel as well as opening of some potassium channel. Phase 2 is the opening of the potassium channel as well as exit of the potassium channel plus entry of the calcium channel. That's why membrane potential remains constant for a long time. That is plateau phase. When calcium channel closes, then repolarization actually begins, and that is due to calcium potassium channel exit. So this is the repolarization phase. Potassium channel remains open and inactivation of the calcium channels. Action potential in non-pacemaker cell is primarily determined by this relative change in the fast sodium, slow calcium and potassium conductance and currents. So if we can prolong this repolarization phase, that means if potassium channel becomes slow or inhibited, then exit repolarization phase will prolong and there will be treatment of this. Thus we can treat the tachyarrhythmia. So remember different phases, and phase 4 is the diastolic repolarization. That means after repolarization there is spontaneously after that there is the tissue remains to the reaches to the resting membrane potential, and when there is again action potential comes, then it goes to the phase 0 again. So this is the defined phases of the cardiac action potential for the non-pacemaker tissue. And remember this refractory periods, once an action potential is initiated, there is a period that a new action potential cannot be initiated. So phase 0, 1, 2, 3. So phase 4 is the excitable time of excitation. That is the time when action potential can excite the excite the tissue. But before that, that means phase 0, 1, 2, 3, that a new impulse cannot initiate, that a new action potential cannot be initiated. This is called the effective or absolute refractory period, and there is stimulation of the cell by adjacent cell membrane. Depolarization also does not produce any propagation of the action potential, and this helps in the limitation of the frequency of depolarization and heart rate. So longer the effective refractory period, that means longer the phase 0, phase 1, phase 2, phase 3, thus there will be benefit in the tachyarrhythmia. SA0 pacemaker potential. Now this was all I have discussed so far is for the non-pacemaker tissue. That means mainly ventricle, Purkinje fiber, his bundle of his. But this pacemaker tissue, that means SA0 pacemaker potential, that curve is little bit different. And here there are only 3 phases: phase 0, phase 3, phase 4. So initially in non-pacemaker tissue, phase 0 is by the sodium influx. Here phase 0 there is little bit lower of sodium, but predominantly it is due to calcium entry. So it is fully repolarized at minus 60 millivolt. There is no stable resting membrane potential. That means it can be excited anytime, and always if action potential comes, this this will reach to the threshold potential rapidly. This from the phase 4 to phase 0, and this phase 4 is also called the phase of the diastolic depolarization. So phase 4 is the diastolic depolarization. Here also there is a role of the sodium channel, calcium channel, potassium channel. Also sympathetic nervous system stimulation, they also increase this phase 4 slope. So that means phase 4 slope can be increased if there is sympathetic stimulation, and also if there is opening of the calcium and sodium current. So it is the spontaneous depolarization or pacemaker potential. There is slow inward sodium channel is open, which is called funny currents. You have read this in the while you're discussing the evabradine. Evabradine blocks this funny channel. That's they decrease the heart rate, and this causes the membrane potential to begin to spontaneously repolarize. So phase 4 helps in reaching the membrane potential to reach to the threshold potential from which impulse can be generated. And phase 0, phase 3, phase 4. So phase 4 is the due to sympathetic stimulation as well as calcium sodium channel. Phase 0 is predominantly due to calcium channel entry, and phase 3 is due to closure of the calcium channel as well as opening of the potassium channel. So during phase 4 there is also a slow decline in the outward movement of the potassium. So phase 0 is calcium entry, phase 3 is the exit of the potassium, and phase 4 is the due to once again entry of the sodium, potassium, calcium, as well as sympathetic nervous system stimulation that increase the phase 4 slope. So how we can treat the arrhythmia? Either we can decrease the phase 4 slope, phase 0 slope, as well as if we can prolong the phase 3. Thus we can treat the arrhythmia. So SNR plasma potential, phase 0 is depolarization primarily caused by the calcium conductance through the L-type calcium channel. Movement of the calcium through this is slow, so the rate of depolarization is slower than in other cardiac tissues. So look here, phase 0 in non-pacemaker tissue is quite steeper. If we go back to this picture, this is quite steeper, phase 0. This is due to sodium channels are rapidly opening, but here calcium channels are relatively slow. So there is little bit decrease in the phase 0 slope in the pacemaker tissue. And this is the phase 3 is due to the potassium channel opening, just like the normal pacemaker, non-pacemaker tissue, and increase the outward hyperpolarizing potassium currents. At the same time, the L-type calcium channel also closed. So during phase 0, there is opening of the calcium channel, but during phase 3, calcium channels are closed. There is repolarization, and there is inward depolarizing calcium currents diminished, so repolarization. So this is the, once again I am repeating. So in non-pacemaker tissue, phase 0 is due to sodium influx, phase 1 is due to closure of the sodium channel and opening of the potassium channel, which causes potassium efflux. Phase 2 in non-pacemaker tissue is due to calcium influx, simultaneous potassium exit is also there. Phase 3, calcium channel closes, that's why only potassium efflux, that is called repolarization. And phase 4 is the stage when there is reaching of the resting potential. When action potential comes, then the cells tissue is excited. But in pacemaker tissue, there is only three phases: phase 0, phase 3, phase 4. Phase 0 is the slow calcium channel entry. Phase 3 is calcium channel closed and potassium channel are open. There is potassium efflux, and after this repolarization, then they reach to the diastolic repolarization, when a impulse will excite them, and due to opening of this some sodium, potassium, calcium channel as well as sympathetic nervous stimulation, then phase 4 will reach to the phase 0 when there is the threshold potential. So I'm not discussing this. So what is an arrhythmia? It is the irregular rhythm, it is an abnormal rate, or there can be a conduction abnormality. So what causes an arrhythmia? There is change in the automaticity of the pacemaker tissue. What is automaticity? That means the phase 4, if diastolic repolarization, so it is called the automaticity. That means it can automatically reach to the threshold potential from the phase 4. But for the phase 0 to phase 4 to phase 0, this transformation, it can happen automatically. This is called the automaticity of the pacemaker tissue. So other non-pacemaker tissue do not have this property. Ectopic foci causing abnormal action potential. So extra tissue, which if it generates impulse or action potential, then there is rhythm disturbance. Re-entry tachycardia, I shall discuss it. Block of the conduction pathway, abnormal conduction pathway like WPW syndrome, when there is extra pathway, accessory pathway, and that also generates the impulse or conducts impulse. Then also there is arrhythmia, and some electrolyte disturbance like hypokalemia, hypomagnesemia, they can, and also some drugs can cause arrhythmia. Remember, all antiarrhythmic drugs are proarrhythmic. That means itself they can cause arrhythmia if dose is increased, because they are decreasing or changing the refractory period of the most of the tissue, and if it is too much, then there is abnormal slowing of some conduction, and that can generate arrhythmia. And hypoxic ischemic tissue, like patients of presence of the myocardial infarction, can undergo spontaneous depolarization and become an ectopic pacemaker. That's why arrhythmia is very common after myocardial infarction. Now there is the re-entry phenomenon. So look here, this is the two pathways. Suppose impulse is coming, and it can go into both way, phase branch 1, branch 2, and when they come together, there is an impulse dies. Suppose if 1 and 2, when there is both are present, one is fast, one is slow. Suppose 1 is slower pathway, 2 is faster pathway. So when there is similar refractory period, there is no problem. But when there is difference in the refractory period or difference in the conduction, then there is problem. So what will happen? Suppose phase 2, so branch, so take this picture. So it is, so pathway 1 is slower pathway, pathway 2 is faster pathway. But remember, slower pathway has shorter refractory period generally, whereas faster pathway has longer refractory period. During refractory period, the impulse cannot propagate. So suppose impulse is coming here and it finds that in the faster pathway it remains refractory, so it goes preferentially to the slower pathway, and then it goes by this pathway, and when they go by this number 3 pathway, then it finds that refractory period is now is completed. That means the cell is now excitable. So impulse will propagate via this pathway now rather than this pathway. So there is then impulse come back to the here to the again. So this will happen when there is difference in the refractory period. So first impulse will go to the excitable tissue always. So as branch 1 is pathway 1 is excitable, it will cause the impulse will go first by this pathway, then when it comes closer to the second pathway, then it is not refractory anymore. That's why it will propagate by this pathway, and thus in the same way when it comes back here, as the slower pathway has shorter refractory period, then also it will find that it is not refractory anymore. Thus impulse will go back to this pathway again, and this circuit will go on. So here it is less refractory period, it is longer refractory period. So initially it will go by this pathway, then when it comes here, there is refractory period is already completed, it is now excitable, so it is goes by this pathway, and when it comes back again, it is not refractory period anymore because of shorter refractory period, and thus this vicious cycle will go on, and if it can re-excite the tissue, a circular pathway of high frequency impulse will become the source of the action potential that spread through the region of the heart of the entire heart. So this is the re-entry mechanism which will cause arrhythmia. So to treat the re-entry mechanism, what we can do? We can make this pathway more refractory so that impulse will not go back to this. Okay, so the faster pathway should be made more refractory so that impulse, there is less chance of this re-entry phenomenon. So what is the role of the rational antiarrhythmic drugs? They restore the normal rhythm, normal rate and normal conduction, and prevent more dangerous arrhythmia. They alter the conduction velocity in SA node and AV node. They alter this phase 0 depolarization or refractoriness. That means either it can be done by the calcium channel block or by sodium channel block. Calcium channel block it is mainly in the pacemaker tissue, and sodium channel block mainly in the non-pacemaker tissue. Phase 0 slope is thus all decreased, and after excitability of the cardiac cells by changing they can alter also excitability of the cardiac cells by changing the duration of the effective refractory period. So refractory period, so sodium channel influx and potassium channel influx alteration or block can cause the decrease in the phase 0 slope, whereas if we can block the potassium channel, then phase 3 will be prolonged. Thus and effective refractory period will also prolonged. So refractory period will be prolonged if we can prolong the phase 0, 1, 2, 3 whatever. So if it can be prolonged by due to potassium channel block, then also there is benefit in the arrhythmia. ERP increase interrupts tachyarrhythmia caused by the re-entry phenomena mainly, and action potential duration increase can precipitate torsades. So too much action potential duration, if it is increased, too much potassium channel block also is dangerous. It can cause precipitate torsades tripointes. That means severe form of ventricular arrhythmia. There is abnormal impulse generation because there is delay in the repolarization. Suddenly heart becomes more excitable, and there is abnormal irregular impulse generation that can happen if repolarization is too much prolonged. That is also called delayed after depolarization. So delayed after depolarization means, so during repolarization, if impulse is very much slowed down, then before reaching the resting potential, if another action potential comes, and that can reach to the threshold potential, and that can generate abnormal impulse. That is called the delayed after depolarization. Also early after depolarization is common if it is happening in the during the phase of the phase 1. So depolarization is from the phase 1 to phase 3. Phase 1 is due to when calcium channel is not opened yet, and phase 3 means calcium channel has been already closed. So phase 3 is the stage of the calcium channel. So if depolarization is too much longer in the first phase, phase 1, during the phase 1, then if a depolarization is present which can excite the tissue, then it is called early after depolarization, but that is not very common. But late after depolarization, that means if phase 3 is too much prolonged, then a next action potential uh, if uh, if generated, that is called late after depolarization, and that can generate torsions G point. I am going into the picture again. Suppose so, this is the normal. So if it is too much prolonged, suppose phase 3 is too much prolonged, and when it, so here look here, it is the threshold potential close to the minus 70. So when this is due to severe prolongation of the depolarization phase, if impulse comes that is close to the threshold potential, then suddenly a depolarization can generate the action potential, and that is called early after depolarization. And if it is, and that is the cause of this ventricular tachycardia or ventricular arrhythmia during if potassium channel block is severe. That's why that can cause torsions G point is. And early after depolarization means when there is the impulse development in this phase. That means it is early after depolarization and late after depolarization. So you understand the re-entry phenomenon, where there is difference in the effective refractory period of the two pathway which is present parallelly, and impulse goes via the slower pathway preferentially because of its shorter refractory period, but when it goes back to the longer refractory period faster pathway, then refractoriness is absent, and then this pathway can be, and after that propagation through the faster pathway, they can go back to the slower pathway again because of the shorter refractory period, and this cycle will go on. Okay, and if we can suppress the abnormal automaticity, then also there is treatment of the arrhythmia. So either we can decrease the phase 0, or we can prolong the phase 3, or we can decrease the abnormal automaticity in the pacemaker tissue. That means phase 4 slope also can be decreased to treat the arrhythmia. So number one is either we have to decrease the phase 0 slope, or by decreasing the phase 4 slope, or we can prolong the phase 3. This is the Vaughan-Williams classification of the antiarrhythmic drug. So number one is sodium channel blocker. That means it will block the phase 0 of the non-cardiac, non-pacemaker tissue. There are three classifications like 1A, 1B, 1C, depending on their slope of the action potential. So class also there is associated potassium channel blockade. They are divided. So class 1A is quinidine procainamide. There is moderate potassium channel block, and there is little moderate decrease in the action potential slope, phase 0 slope. So quinidine procainamide not only sodium channel block, there is also blockade of the some potassium channel. That's why they also increase the action potential duration. Whereas class 1B lignocaine, they do not have this potassium channel blockade action. That's why they have no effect on the action potential duration. Class 1C flecainide, they have also potassium channel blockade action, and their action is very prolonged. Sodium channel blockade is prolonged for the class 1C, and there is little slow acting, so there is more decrease in the phase 0 slope. So class 1A actually there is moderate decrease in the phase 0 slope. Class 1B mild decrease in the phase 0 slope. 1C there is significant decrease in the phase 0 slope. So quinidine procainamide, remember few example. Class 1B lignocaine is also phenytoin. There is sodium class 1B. Class 1C is flecainide. Beta blocker is phase 2. That means beta blocker acts in the pacemaker tissue to decrease the automaticity. That is, the phase 4 slope is decreased by the beta blocker, metoprolol esmolol. Class 3 potassium channel blockers, amiodarone, ibutyrate, dofetilate. That means they act on the phase 3 to prolong the phase 3 so that action potential duration can be prolonged. Phase 4, class 4 is calcium channel blocker, verapamil. That means calcium, where it is important in the pacemaker tissue. SA note, it will decrease the phase 0 slope in the pacemaker tissue. So calcium channel blocker are helpful in there. And other deoxynitrogen, magnesium sulfate, atropine, there are other drugs which can be used in different kinds of arrhythmia, but major drugs are this class 1, 2, 3, 4. Quinidine, lignocaine, flecainide, beta blocker and calcium channel blocker are phase 2 and phase 4, and potassium channel blocker, remember the amiodarone. So now brief discussion about different drugs. Class 1A agent, it blocks the activated open and activated sodium channels. They slow the phase 0 depolarization. The upstroke of the action potential is slowed down, and also block some potassium channel, and that due to this there is prolongation of the action potential duration as well as effective refractory period, and there is prolongation of the QRS duration. Some of them has anticholinergic side effects, and they are having greater affinity for the rapidly firing channels. That means faster the heart rate, more will be they are active. Quinidine is used in the treatment of the SVT and VT, and also torsades spontis, that is the ventricular arrhythmia. Procainamide is another example. So remember this, quinidine, procainamide. Class 1B, very commonly used in the treatment of the ventricular tachycardia due to myocardial infarction. They block the inactivated sodium channel mainly. They slow the phase 0 depolarization, slow upstroke of this action potential, but they shorten the action potential duration. So unlike the other antiarrhythmic, this is the exception of the lignocaine. They will shorten the action potential duration and effective refractory period, because they block some sodium channel which are opening due to even after closure of the sodium channel in the phase 1, and due to the sodium channel block there is rapid repolarization in the with the lignocaine, and that's why action potential duration is shortened. And there is greater affinity for the ischemic tissue that has more inactivated channels. So class 1A mainly act on the activated sodium channel, class 1B mainly act on the inactivated sodium channel, and this is present mainly in the ischemic tissue, little effect on the normal cell, and this dissociates very quickly. So sodium channel inhibition, it is very lignocaine acts very short time, and remember for it is useful for the ventricular tachycardia only. Atrial tachycardia or atrial arrhythmia, ventricular lignocaine is not effective because atrial action potential duration is already very short, and lignocaine cannot bind it properly because lignocane binds dissociates very quickly from the sodium channel, and this inactivation of the sodium channel in the atrial tissue is also very short. So lignocaine is used in ventricular tachycardia in heart with normal ejection fraction, mainly used in the myocardial infarction induced tachycardia, ventricular tachycardia. Phenytoin is another example. Class 1C, it blocks the sodium channels. Most potent sodium channel block also dissociate very slowly. So lignocaine dissociate very fast, and class 1C like flecainide dissociate very slowly. It strongly depresses the conduction in the myocardium. So here phase 0 slope is very much decreased, slope of the phase 0 slope. So it slows the phase 0 repolarization, but there is no effect on the action potential duration, no effect on the QRS. And flecainide can be used in the treatment of the atrial fibrillation. Another example is propafenone. So remember class 1A, 1B, 1C, they are mainly sodium channel blockade. Class 1A has some potassium channel blockade action. Due to that's why they prolong the action potential duration. Class 1B, lignocaine, mainly used in treatment of the myocardial infarction associated ventricular tachycardia, no use in the atrial tachycardia. Class 1C, it slows down the action potential slows down the phase 0 slope maximum because of their slow dissociation, prolonged duration of action, and it can be used in treatment of the atrial fibrillation. Class 2 agent, beta blockers, so they block the beta 1 receptor in the heart, and they decrease the automaticity. That means they decrease the sympathetic nervous system activity, and thus they decrease the diastolic depolarization or phase 4 slope. So phase 4 slope is decreased by the beta blocker in the pacemaker tissue, and in non-nodal tissue they increase the action potential duration and the effective refractory period. Say in SA node and AV node, they decrease the sinus rhythm. They decrease the conduction velocity and block the re-entry, inhibit the aberrant pacemaker tissue activity. So class 2 is beta blocker. We can use metoprolol, esmolol, atenolol, etc. Class 3 agents, also they can be used in treatment of the atrial fibrillation. They block the potassium channel mainly. They prolong the repolarization. They prolong the action potential duration and effective refractory period. So potassium channel blocker are mainly they are prolonging the phase 3. So they prolonging the they delay the development of the resting membrane potential, uh, and thus they decrease the decrease the chance of the further impulse propagation because they prolong the action potential duration. And thus this phase 3 drug, if it is overdosed, there is risk of the cardiac arrhythmia, that is development of the late after depolarization and development of the ventricular tachycardia. If it is severe, it can cause tortuosity pointes. Useful in the re-entry tachycardia, because in re-entry tachycardia, which I have mentioned that already there is difference in the fast pathway and slow pathway. Fast pathway are more refractory, slow pathway are less refractory. So re-entry can be prevented if we can increase the refractoriness of the faster pathway further. Fast pathway is already having higher refractory period, longer refractory period. If we can prolong the refractory period further of the faster pathway, then impulse cannot propagate again through the fast pathway. So go back to this picture of re-entry. So re-entry is happening because it is fast pathway, it has longer refractory period, and impulse is fast propagated via the slow pathway, which is having shorter refractory period. But when impulse coming to this, if it finds that it is not it is excitable, then only it will travel through this. So if we can increase the refractoriness of this pathway more, so that impulse will find this after reaching here, if the impulse finds it is still now refractory, then it will not propagate, and thus we can prevent the re-entry. Thus, to treat the re-entry, we have to increase the refractoriness of the faster pathway. Thus, phase 3 class 3 drugs are very effective. Example is amiodarone, sotalol. These are the commonly used drug. Also ibutylate, dofetilide. Ibutylate, dofetilide are pure potassium channel blocker. Amiodarone have additional effect. Amiodarone can have additional sodium channel blockade as well as beta blockade action, as well as potassium channel blockade. So amiodarone have effect of the class 1, 2, 3, whereas sotalol a beta blocker, but it has some additional potassium channel blockade action. So it is a beta blocker having class 2 and 3 effect. So amiodarone have class 1, 2, 3 effect, sotalol having class 2 and 3 effect, whereas ibutylide, dofetilide, they are purely class 3 because of they block the potassium channel mainly. So amiodarone, you have to know it in detail. It is useful for the most of the tachyarrhythmia because of its wider spectrum of action. It is a sodium channel blocker, it is a potassium channel blocker, also it acts as a similar to the beta blocker to reduce the automaticity of the pacemaker tissue. And it can be given in patients of the impaired left ventricular function also. It controls the rate, and it also converts the rhythm to the sinus rhythm. And in cardiac arrest, we can give it 300 milligram IV. Stable ventricular tachycardia, we can give 150 milligram repeated after 10 minutes, or infusion 360 milligram IV for 6 hours. Dosing is not so much important, but remember the amiodarone, it can be used in full in treatment of the most of the tachyarrhythmia, mainly ventricular tachycardia, and it has some side effects which you need to remember. That's why its use should not be a blanket use. Any arrhythmia, whatever mild may be, initially amiodarone use should not be given unless it is very much needed, because it has multiple adverse effects. It can cause the photosensitivity, it can cause thyroid disorders, it can cause both hypothyroid as well as hyperthyroid, because amiodarone contains a significant amount of the iodine, and iodine, if it is overdosed, then it can block the generation of the thyroid hormone synthesis, and thus it can cause hypothyroidism. Whereas in some area it can cause thyroid hormone excess release also, that is all, then it causes thyrotoxicosis. So both thyroid hypothyroidism and thyrotoxicosis that can happen with the amiodarone. That's why we have to check the thyroid hormone frequently. And there is also pulmonary alveolitis, pulmonary fibrosis, and corneal microdeposit also there, and there can be development of the peripheral neuropathy. So these are the adverse effects of the amiodarone, but it is very useful in the treatment of the ventricular tachycardia. And next is class 4 agent, that is the calcium channel blockers. They bind to the L type calcium channels and vascular smooth muscle, cardiac nodal and non-nodal tissue. All calcium channel blockers, also there is also inhibition of those calcium channel also. They decrease the firing rate of the apparent pacemaker site. So when the calcium channel blockers are responsible for decreasing the phase 0 slope of the pacemaker tissue, phase 0 of the non-pacemaker tissue is mainly done by the sodium channel, but phase 0 of the pacemaker tissue is done by the calcium channel. So calcium channel blocker will block that phase 0 slope. And so they decrease the conduction velocity, they prolong the repolarization. So when calcium channel blocker is given, there is repolarization, there is further increase in the repolarization. So they are especially activated at the AV node, and example is verapamil dilitiazine. So verapamil, there is useful in the nanocomplex tachycardia. Nanocomplex tachycardia means that is generated above the ventricle. So generally ventricular tachycardia having wider complex, that means QRS complex is wider, and narrow-complex means QRS complex is shorter or is narrower. This is depending on the duration of the QRS complex. QRS complex, if it is 0.12 second or less, then we call it a normal QRS. If it is more than 0.12 second, then we call it a wide complex tachycardia. And for wide complex tachycardia, remember, it is ventricular tachycardia, then drug of choice is amiodarone. But for narrow complex tachycardia, we can use this calcium channel blocker, verapamil, because narrow complex tachycardia mostly generated from the SA node, AV node, and it terminates. That's why paroxysmal supraventricular tachycardia or supraventricular tachycardia, that is called PSVT or SVT. Rate control is in atrial fibrillation, atrial flutter can be done by this verapamil, but it is not used in the WPW syndrome, and verapamil must not be used with beta blocker because they are used together will cause significant decrease in the heart rate, and there can be significant conduction abnormality. Often heart failure can be precipitated if there is decrease in the contractility also. And high dose can cause hypotension, and dilitiazem has less adverse effect, but verapamil is more effective. So when there is supraventricular tachycardia, verapamil is the drug of choice among the calcium channel blocker because it has significant decrease. It can significantly decrease the cardiac conduction. Next, another group of drug is adenosine. It is not classified under any group. It is a nucleoside, purine nucleoside, acts on the A1 type of adenosine receptor. It opens acetylcholine sensitive potassium channels. And what is their action? So, you go back to the action potential curve. So, this is the resting membrane potential, and amiodarone, by opening the potassium channel, that is acetylcholine sensitive potassium channel, they will further decrease this resting membrane potential so that cells are hyperpolarized and there is difficulty in propagation of impulse generation or propagation of the action potential. So they hyperpolarizes the cell, and thus action potential propagation can be prevented. So opens acetylcholine sensitive potassium channel, inhibits calcium current also. They suppress the calcium dependent action potential, and this is called hyperpolarization. That's why there is less chance of the action potential development in the excitable tissue. It inhibits the AV node mainly, and due to this AV nodal refractoriness, as they increase the AV nodal refractoriness, there is used in treatment of the paroxysmal or supraventricular tachycardia. Supraventricular means impulse is generated above the ventricle, either from the atrium or from the AV node, and if we can use adenosine, then all the impulse will not come to the ventricle, because main treatment of arrhythmia, we have to decrease the ventricular rate as far as possible. So in atrial fibrillation, we can use digoxin, which will, if you remember, atrial fibrillation in digoxin, it will increase the conduction, it will increase the refractory period of the AV node by its vagal action, vagomimetic action. So digoxin will cause decrease in the AV nodal, increase the AV nodal refractoriness. So AV nodal conduction velocity will decrease by the digoxin. That's why all the impulse from atrium is not coming to the ventricle. Thus, atrial fibrillation can be treated by the digoxin. Similarly, paroxysmal supraventricular tachycardia, when impulse is coming from the AV node or atrium, if we can increase the refractoriness of the AV node, then all the impulse will not come into the ventricle. Okay. It enters the re-entry and aberrant pathways through the AV node. Diagnosis and treatment of the PSVT is also done by this. So treatment of PSVT is treated by the adenosine, and often it is difficult to diagnose from the ECG whether it is SVT or VT, supraventricular tachycardia or ventricular tachycardia. Often, if we give adenosine, if it reverts to the sinus rhythm very rapidly, then it is a confirmatory. So it can be used as a diagnostic test of the SVT. And SVT, but it is not used in the atrial flutter or fibrillation or ventricular tachycardia. So when there is impulse is generated from the AV node or from the atrium, which is regular, then PSVT adenosine can be used. But in atrial flutter and fibrillation, heart atrium is generating impulse very irregularly, then dioxin is the drug of choice, not the adenosine. So contraindications, we cannot use in hypotension. Adenosine also constricts the bronchus, so in asthmatic patient it is avoided, and bronchospasm is adverse effect. But remember the unique property of the adenosine. Adenosine is a very short acting drug, and that's why it needs to be reached to the heart very rapidly soon after injection. So it is given rapid IV push, 6 milligram, 12 milligram, 12 milligram, 3 doses tried, so to see whether it is going back to the sinus rhythm. So carotid massage is done first, vagal maneuvers first. So vagal maneuvers actually will increase the refractoriness of the heavy node, and often sometimes SVT can be treated by this vagal maneuver also. But when it is not successful, then we are giving adenosine. And remember, adenosine is given such like that it should be done in a large vein, preferably central vein. And after the injection of the adenosine, we have to keep another syringe ready, so that and with the syringe we push that adenosine. So in first syringe we are giving adenosine, with the second syringe we are pushing water, so that this water by the force will push the adenosine rapidly to the heart, because its duration of action is only few seconds, 12 seconds. So within 12 seconds it need to reach to the heart, and it flashes with the 20 ml of normal saline. So this 20 ml flashing of the normal saline is needed, so that it is reached to the heart rapidly. It records and also this is the common adverse effects. It can cause flushing, chest pain, and rarely it can cause asystolar bradycardia. So remember this adenosine. And next is digoxin. It is a cardioglycoside. It blocks the sodium potassium ATPase pump. It is mainly used in treatment of the atrial fibrillation because it increases the alveolar refractoriness. So this is the arrhythmia. So antiarrhythmics are also proarrhythmics. It has dangerous side effects. And remember few commonly used common arrhythmia. How we can identify that? This is the busy slide. Remember, so arrhythmia can be tachyarrhythmia and bradyarrhythmia depending on the heart rate, and tachyarrhythmia also can be ventricular or atrial or supraventricular. So what is the basic, how we can identify? If QRS complex is wide, then it is ventricular. If QRS complex is normal, that means between point up to 0.12 second, then it is supraventricular or atrial. If it is regular and narrow complex, then it is a supraventricular tachycardia. And if it is irregular, rhythm is irregular and it is narrow complex, narrow QRS, then it is a atrial fibrillation. So irregular narrow complex tachycardia is atrial fibrillation, or atrial flutter fibrillation is more irregular. In atrial flutter, there are sometimes there is regular, sometimes there is irregularity, and atrial flutter is commonly associated with some associated heart block that can be identified as presence of multiple P waves and after that some of the QRS are complex, which means all the AV nodes, all the impulses are not reaching to the heart. So atrial flutter and fibrillation, you can see it by its irregular rate as well, irregular rhythm as well as narrow complex, whereas supraventricular is regular narrow complex, and ventricular tachycardia means it is regular but wide complex, and ventricular fibrillation is irregular and wide complex. So atrial fibrillation, narrow complex, irregular. Supraventricular tachycardia is narrow complex, regular. Atrial ventricular fibrillation, irregular and broad complex. Ventricular tachycardia is regular and broad complex. So broadly we can divide these different kinds of arrhythmia, and we can treat the different arrhythmia according to their origin. So remember, sodium channel blocker are used in treatment of the ventricular arrhythmia, because they are not used in the treatment arrhythmia generated for the SA node AV node, because sodium channel blocker are not used decreasing the phase 0 slope of the pacemaker tissue. That's why calcium channel blockers are more effective in the that verapamil is very effective in the treatment of the SVT because they decrease the evinodal phase 0 slope, whereas class 3 drugs, potassium channel blockers, they are very effective drug in the treatment of the arrhythmia generated from the re-entry. Also different kinds of ventricular arrhythmia also, when there is, we need to increase the action potential, duration or effective respiratory period. And beta blocker is and lignocaine, the phase 1b drug, they are useful in treatment of the myocardial infarction related ischemic ventricular tachycardia. So according to their response, according to their source of the arrhythmia, we can use different drugs for effective treatment. And note down few questions which you need to remember. Number 1, mechanism action of amiodarone. Mechanism action of the amiodarone, shortly 3 points need to be written. Number 2, common adverse effect of amiodarone. Number 3, how we can treat re-entry arrhythmia. Number 3, how we can treat re-entry arrhythmia. Number 4, drug of choice for the paroxysmal supraventricular tachycardia or PSVT. Number 4, drug of choice for paroxysmal supraventricular tachycardia, PSVT. Number 5, calcium channel blockers are not useful in treatment of the ventricular arrhythmia. Why? Calcium channel blockers are not useful in treatment of ventricular arrhythmia. Why? Number 6, sodium channel blockers are not so much effective in treatment of the atrial arrhythmia. Why? Okay, so these to explain why calcium channel blockers are preferentially not used in treatment of the ventricular arrhythmia, why sodium channel blockers are not used in treatment of the atrial arrhythmia, and mechanism of action of amiodarone, mechanism of action, how we can treat the re-entry arrhythmia, side effects at common adverse effect of the amiodarone, and another question, what is the drug of choice for the PSVT? Okay, answer this. If any query, you can ask me.